Right. Hello, everybody. My name is KG. I am the host of The Movements, a podcast history of the masses, an audiobook style podcast that mixes narrative drama with scholarly analysis to bring to life complex histories of political upheavals, liberation struggle, and revolution. I want to thank Dr. Cooper for reaching out to me and offering his experience and offering to teach us how to control bleeding, buy time, and save lives when access to emergency medical services is not available. We don't quite know how the coming days and weeks are going to play out. So, all I can say is that we are proud of all of you for showing up and for being part of the long, proud tradition of democratic struggle throughout history. I'm going to ask folks to keep their video and audio off. If you have questions, please ask it in the chat box. You may also use the private message feature in Zoom to send me your questions directly, and I'll read the questions after Dr. Cooper finishes his training. If I think it's important to ask it immediately, I'll go ahead and interrupt as well. And as a safety measure, we just ask that you have good judgment about whatever you type into the chat box. We're here to prepare you to buy precious time and save lives. Once you have this knowledge and you leave this training, you do what you do. The training is being recorded and it will be uploaded as a publicly available resource. If your question is unanswered by the end of the hour, we'll do our best to follow up. An email will be sent to all registrants with the recording and follow-up answers. Dr. Cooper, it's all yours.
Thank you so much for having me, KG. So I'll talk just very briefly about my background and kind of my motivation for doing this. So my name is Max Cooper. I'm an emergency physician. I trained in downtown Philadelphia, and then I was part of the U.S. Navy deploying to Afghanistan for a period of time and working in a combat trauma hospital next to the Helmand province, where I saw frequently, very significant traumatic injuries. And I wanted to kind of share some of my experiences with you and some of my training with you. Nothing that I'm teaching you is dangerous or confidential or in any way secret. It's all really basic medical care that we train all of our doctors, nurses, EMS workers with. And, the more you know, the more you could help someone, just in case you're in a scenario where, for whatever reason, EMS isn't able to help. So I'm just going to share my screen, and then we'll get to some slides. And again, if any questions come up, just chat them into the chat box. KG will interrupt me if it's appropriate, or voice your questions at the end. And then I'll have kind of a live demonstration that I mocked up to review how to apply some tourniquets. All right. So again, this is a demonstration of street-side bleeding care and techniques. This is me and my background. If you want to follow me on Twitter, I'm @MaxCooper0. All right. So this is a quote by R. Adams Kelly. He's really the father of trauma medicine in the United States. And I think this is really kind of an apropos way to start. So the first hour after injury will largely determine a critically injured person's chances for survival. All right, so this is kind of the entire concept of what we're teaching today. Is the actions that are taken early could really set the stage for someone's survival. If you intervene early, you can save a life. If you or EMS isn't able to, make an intervention, someone could, die. So we're going to go over a number of different topics today. We're going to kind of go over the basics of trauma care, discuss some historical perspectives on tourniquets, different kind of scenarios to consider when these techniques will be most applicable. And then we're going to get into the meat of this kind of bleeding control. We're going to talk about direct pressure, how to pack a wound, how to use a tourniquet. And then I save time at the end for questions and demonstration. But if anything I'm saying is confusing, please feel free to interrupt me, KG. I'm used to lecturing to a medical audience, so I'm not used to, I don't know what you don't know, and I'm happy to answer questions that are extremely basic. Please don't be embarrassed to ask anything. All right. So trauma care basics, getting into it. So the major cause of death and disability in young people, is trauma. Most of us will be otherwise healthy until something awful happens. A car accident, falls, an injury of whatever kind. Trauma, death is a major cause of mortality in our age group. So these deaths are classically described as having a trimodal pattern. So I'll discuss this a little bit more later, but basically have people that die immediately, people that die late from kind of secondary sequelae like infections, and then you have the people who kind of die in that intermediate phase of time, and that's really where we're going to be intervening. So this concept of a golden hour is basically this idea that you have this critical period of time to make an intervention to get the person to that place for definitive care. And if that intervention is made, if they get to that place for definitive care, the likelihood of their death and disability, that they die or they're disabled, goes down dramatically. And if they don't get this intervention, they don't get transported to a place for definitive care, the likelihood that they die increases. So certain field technologies, certain techniques we can conceptually think extend this hour of survivability. So this trimodal pattern of trauma, what am I talking about? So there's certain injuries that will kill someone immediately. There's nothing that you can do. They're not survivable. Think about like overwhelming hemorrhage. Think about anything that causes somebody to be unable to breathe. These things will unfortunately kill people very quickly. And on the other end of things, there's things that kill people late. They survive, but they get some sort of secondary infection. We saw this all the time in Afghanistan, where the insurgents there, they were very smart. So they actually strapped dead animals and feces and things like that to their explosive devices, which caused these infections in everyone who was exposed to that. And so, we would take care of them and stabilize them immediately, but over days to weeks, they would all get infections and require really long-term antibiotics, and really complicated the care that we provided. And then there's the kind of early, so these people who could theoretically die in minutes to hours. And that's really where the training that we're providing today will allow you to intervene, because most of these people die from hemorrhage, bleeding related issues. And if you know how to control the bleeding, you can decrease the likelihood that they'll die. All right. So we control the bleeding through multiple techniques, but the kind of one that we're going to focus on really today is tourniquets. Now, this is a technique, a device that's been around for a very long period of time. The first known recorded use was the Battle of Flanders in the late 1600s. It saw widespread use in the US Civil War by both Confederate and Union soldiers. At that time, it was used with very little training. It was frequently used in situations where it was unnecessary and excessive, which led to unnecessary damage and limb loss. But when used properly, it was life-saving by limiting blood loss. And throughout history, it's been both criticized and praised for its ability to save life, but when used incorrectly, its ability to kind of damage limbs. So this is just a diagram of a very early tourniquet, just so you can kind of have some historical perspective. This particular device is called a petite tourniquet, and you can see the kind of screw on top is used to slowly tighten pressure on an arm or a leg until all blood flow that goes past it is cut off. And this is a more modern tourniquet. This is the kind of standard design that you'll see. You can buy them at most sporting goods stores. You can buy them on Amazon and other online retailers. I have a very similar model that I'll be demonstrating the proper use of at the end of this webinar. So some scenarios to consider. When are you going to need to put this on, as opposed to when you'll get some standard EMS care? So the kind of impetus behind me reaching out to KG was, we see all these, these protests, these legitimate protests, part of the Black Lives Matter movement. There's protests for a variety of reasons, but this is kind of what's in our consciousness right now. And unfortunately, some of these are turning violent. And whenever you have a large crowd of people, if there's an injury that occurs, somewhere in this middle part of the crowd for whatever reason, because of the density of people. It would be a prolonged period of time before EMS workers, ambulances are able to gain access to these folks and intervene on them. And so there's going to be a prolonged period before they can get to hospitals and surgeons and definitive care. So the training you get today could help in this scenario. This is a photo of Hurricane Katrina. So really any time that you have delayed access to emergency care, there's the potential for an otherwise survivable injury to become fatal due to basic blood loss issues. You can see this all the time with multi-car pileups. I have a tourniquet and a first aid kit I have in the trunk of my car. You never know when you're going to use it. And some people might recognize this picture. This is I feel like when tourniquets really came to public consciousness broadly, this is a photo of the Boston Marathon bomber, or bombing event, I should say. And tourniquets really widely used there because there are so many extremity injuries. So you really never know when this sort of skill, these techniques will come in handy. So I recommend a stepwise approach to bleeding control. So the first step of this is you got to identify this is a life-threatening bleed versus some not life-threatening bleed. Then when you recognize there's a bleed, you need to expose the wound and really understand how big it is, how deep it is, where it is. And so I'll discuss how to do that. And then once you identify it and you expose it, there's a stepwise series of techniques that you can do. You do direct pressure, which basically just means you put your weight on it, see if that stops it. If that doesn't, you can move on to wound packing and pressure. And ultimately, if that's not successful, tourniquet use. So how do you identify a life-threatening bleed? So these are some photos that I pulled out of a publicly available teaching document from an organization called Stop the Bleed. And all of my references are at the end, so feel free to peruse those. So some things that signify this is a life-threatening bleed. If you see blood spurting out of the wound, projectile squirting of blood, that's life-threatening. Or a very steady ooze, blood that won't stop coming out of the wound, like a steady stream of blood. Pooling on the ground. Bandages and clothing that is totally soaked through. If part of somebody's arm or leg is missing or significantly disfigured. Or if you see bleeding and the person appears confused or pale or sweaty, these are all indications that it's a life-threatening amount of bleeding. So the next concept is exposure, right? So we need to not only say, yes, this is bleeding, but where is the bleeding and what is the extent of the injury? So this is a commonly available device. It's called trauma shears. We have them in the hospital. Many people, have them in their first aid kit. EMS crews have them in their rigs. Anyone can get them. Anyone in the lay public can get them. They're just a couple bucks on online retail. So you use this, and they're special. They're very well-designed scissors, basically, and they allow you to cut through very thick material, thick things like jeans, zippers, buttons. I've seen these things cut pennies and quarters in half. So anywhere that somebody's bleeding, even if they're wearing very thick clothing, you can use these trauma shears to cut through their clothing, identify the exact extent of the injury. And then when you can visualize it, you know what to do next. So the first step to control bleeding is direct pressure. So you take a clean cloth, you take gauze, you take any sort of fabric, easily folded material, preferably unsoiled and relatively clean. You kind of wad it up, you apply it directly to the wound, and then you take your entire weight on your two hands and really just apply as much pressure as you can using your weight. And what that will do is if you apply enough pressure, this should kind of pinch the blood vessel shut, limit the amount of bleeding, allow coagulation to occur where clots will form and the bleeding will stop. So lower severity injuries will generally respond very well to direct pressure. Very severe injuries, generally direct pressure isn't enough. And so a stepwise approach, if direct pressure doesn't work, is wound packing. And we kind of talk about this concept of wound packing. If you consider blood vessels, there's two types. There's arteries and veins. Arteries take blood away from the heart towards parts of the body, and veins take blood back from the body parts to the central part of the body, the heart. And so the anatomy of these arteries are muscular and they kind of act like springs. So if an injury is deep enough, an artery can retract up a leg or deeper into an arm. And that's why direct pressure doesn't work, because the blood vessel that's bleeding is no longer present at the wound site. It's backed up a few inches. So if you pack these wounds with clean cloth, with fabric, with these medical gauze packets, that allows kind of direct pressure to be applied to the blood vessel that's bleeding. Additionally, you can't apply a tourniquet to any central part of the body, neck, chest, abdomen. So if you have a deep injury to the neck, chest, or abdomen and somebody's bleeding rapidly from it, tourniquet use isn't an option there. So really the only thing you can do there is direct pressure and wound packing to control bleeding there. When the wound is packed with this clean cloth, this fabric material, you should then put both your hands on it. And just like direct pressure, use all of your weight to try to control the bleeding and close off the blood vessels in that manner. So now we're going to get into some basic anatomy that kind of explains why we use tourniquets the way we do. Sorry for the low quality. These are essentially copy paste from my med school anatomy textbook. So this is a cross-sectional diagram of, on the left, somebody's upper arm, and on the right, somebody's forearm. Now, one thing that you'll notice, there's one arm, the humerus, in the upper, sorry, there's one bone, the humerus in the upper arm, and there's the radius and ulna in the lower arm. And so by having one arm, if you had a strap apply direct pressure circumferentially around this, it's going to squish all the blood vessels equally. The forearm, if you had a strap that applied direct pressure here, there's certain blood vessels that are in the central part of the arm that would be spared that direct pressure because of the way the bones are kind of organized in that structure. So if you applied a tourniquet to a forearm, or if you applied a tourniquet to the lower leg below the knee, it might be partially successful at closing off blood vessels. Maybe this one, certainly these more superficial vessels. But it's possible that you're going to have continued bleeding even with a significant strap tightening, just because the bony architecture in that part of the arm or leg is preventing pressure from being applied to these vessels. And so if you have what we call a distal injury, an injury farther out from the central part of the body, we recommend applying a tourniquet 3 to 4 inches kind of above that, more centrally. But if that's going to be in the forearm or the lower leg, it still might not be enough pressure to control it. So even if they have a distal injury near the wrist, an injury near the ankle, a tourniquet applied above the elbow or above the knee, you can see here diagrammatically, would be more successful at closing off all the vessels, just because there's no bones that are preventing that pressure from being applied. And really, really important concept here, you never want to apply a tourniquet to a joint. So you don't want to apply it on a knee. You don't want to apply it on an elbow. The kind of bony surfaces there prevent appropriate pressure being applied to the blood vessels. So you always want to go above the knee, above the elbow, if you're going to be placing it in that region. And likewise, here's the analogous anatomy in the leg. So here's the upper leg, the thigh, and you can see one bone, the femur, and there's the major blood vessels are adjacent to that. So pressure applied in a strap-like circumferential distribution is going to apply pressure to all the blood vessels. And just like the forearm, the lower leg here, you have the tibia and the fibula, and you can see there's some central blood vessels. So even if you had an immense amount of pressure being applied in a strap, these bones are going to prevent that pressure from being transmitted to these blood vessels, and you would still have some amount of bleeding here. It would probably slow the bleeding, but you'd probably still have some bleeding here. And so if you have a really significant injury and you're not able to control that bleeding with the tourniquet in the lower leg and the forearm, you can always put it above the knee, above the elbow, to get better bleeding control. All right, so the kind of meat of the lecture here, how to apply a tourniquet. So there's 4 major components to this, and I'll demonstrate this on a yoga mat afterwards. So there's a strap. You want to pull the strap. You want to put the arm or leg through the loop of the tourniquet, and you want to tighten the strap as much as you can. And you'll see here in the upper right, there's this spinning action. That device is called a windlass. And it's basically a stick. And every time you spin it, it slowly tightens it a little bit more. And then you want to get it as tight as you can. You'll know you're successful when you see the injury is no longer bleeding. You see in the upper left, bleeding injury. As they tighten the windlass, you see patient no longer bleeding. And now, once that windlass is tightened, there are these little hooks that you can put it in, and that'll prevent it from unwinding. So you put it in the hook, and then there's a little Velcro loop that you can apply over it that keeps it secure on the hook. And there's a little blank area there. If you have a pen or a Sharpie marker on you, you can write the time the tourniquet was applied. And that'll be helpful for EMS workers or hospital workers who are evaluating a patient later, so they know how long this tourniquet has been applied for. Not everyone is going to have these devices, although they're relatively inexpensive. You may not have access to one when you need it. And so there are ways to kind of jerry-rig or MacGyver a tourniquet. All you really need for this is some sort of cloth that you can wrap around an extremity. So this looks like a basic bandana here. And you need a stick, a pen, some small rod. And so you wrap the extremity with the fabric, and then you put the stick in there and you wrap that around so you get this. And then from this, you twist it just like the windlass in the previous diagram, and that slowly tightens that fabric even further. And you want to tighten this until you see that there's no blood coming out or oozing, spurting out of the injury that's past this. And then you can just use another piece of fabric to secure it, just like the loop in the commercially made tourniquets. So are there any questions, KG, that popped up?
We do have one question. Let me read that out for you. So the question we have here is, if you don't have access to shears, is it more important to take time exposing the wound or applying pressure, wound packing, etc.?
So I would say pressure is the best thing to do. The reason we like to expose is you often don't know where to apply direct pressure. So, you might see a large amount of blood. And so do you apply pressure right above the knee, a foot above the knee, below the knee? There's blood everywhere. I don't know what to do. And so cutting off that pant leg, cutting off the shirt, kind of allows you to better understand what you're dealing with and how to intervene. I would say if you don't know what's going on, try to apply pressure as best you can. Get shears of some kind. Any scissor will do. A pocket knife would work in a pinch, and try to remove that clothing. If you don't have that, you can just have a friend remove the patient's pants, shirt, what have you, to gain exposure, and then you can do that. So I guess it's hard to say what to do more. Direct pressure will stop the bleeding, but if you don't apply direct pressure in the right spot, it won't be helpful. So they're both important. Just try to expose the patient any way you can. Good question. Any other questions, KG?
All right, we have one other question here. I see. Is there a time limit that the tourniquet can or should stay on?
Yeah, it's a great question. So the quicker they get to a hospital and the tourniquet is removed, the better for the patient. But it's important that it be removed in a place where kind of definitive surgical care could be applied. I have, in Afghanistan, seen patients brought in after having the tourniquet on for 2 days. They survived. Their leg did not, but they did. And if the tourniquet wasn't in place, they would have died long before they came to the hospital. So a tourniquet, it's really important. It's not instead of a hospital. It's not instead of calling 911. It's not instead of getting EMS or first responders there. It's in addition to if they're delayed getting there. So As soon as that tourniquet is applied, you should get that person to a hospital as soon as possible. But you should apply the tourniquet as soon as you kind of identify that there's life-threatening bleeding. But yeah, 2 days is the longest I've seen. I imagine you could go longer, but the longer you go, there's kind of secondary causes of death that develop.
All right, thank you. Next question we have here. What kind of triage? What if the immediate situation is not conducive to treating a patient and they must be moved? What if police are hampering medical personnel's ability to treat victims?
Yeah, I would say anytime you're in a situation that's not safe, if you get injured, you're not going to help your buddy. It's just that simple. So the first thing they teach, EMS trainees is the scene safe? Asking, can I go to this place to safely intervene? Is there an active shooter? Is there a power wire down? Is there violence occurring for whatever reason? If the scene's not safe, you shouldn't put yourself in a situation where you're going to get injured, because now there's two people who need help instead of the one person. That's not going to help anyone. So I would say ensuring scene safety is the top priority, and then intervening on the person. So if you can move them to a place that's safer to help them, if you can somehow make that scene more safe so that you can help them, but having multiple people injured isn't helping that first person. Good question.
Thank you. Next one we have here. Is there any contraindication regarding painkillers when dealing with these kinds of wounds?
No, this is a really, really good concept, and thank you for bringing it up. I forgot to bring it up. So when you crank that windlass tight and you cut off blood supply, it's going to be very, very uncomfortable. The patient will be in pain. There's just no way around it. If you apply that tourniquet correctly, it will not feel good. And so if you need to give pain meds, whatever you have on you, I won't go into the details of, pharmaceuticals, but if you need to give painkillers of some kind, I think that's appropriate.
Great. Next up we have here, when trying to expose wound and clothing is somehow stuck to skin enough that it might rip if you take it off, is it more important to keep trying to expose or go straight to direct pressure?
Yeah, I would just try to get the clothing off as soon as possible. So, we do this, multiple times a shift in the emergency department. It's a standard part of our primary survey is identify all the injuries, remove all the clothing. I've never seen clothing stick to someone outside of severe kind of burns and melted clothing. And even in that situation, the clothing is usually melted enough that you can kind of see the extent of the injuries through the melted clothing. The standard kind of shredded blue jeans, shredded t-shirt, that stuff's not gonna, 9 times out of 10 cause any issues. If for whatever reason the clothing is stuck despite your attempts to scissor or cut it off, as long as you know basically where the injury is and you have a basic understanding of the extent of the wound edges, start applying pressure. Don't delay that as soon as you have an understanding of the injury.
Next up we have here, given that a lot of people wear belts, would a belt work as far as makeshift tourniquet in a pinch, or would you recommend cloth plus stick still prevail as recommended items?
So the things that work best are non-stretchable items. So like a leather belt, that could work really good. A cloth that you tighten, that would work well too. Depending on the specifics of the belt, it might be hard to get that windlass twisting device in, but it might be really good for that initial kind of looping part of it. I would say if I had to choose like a widely available device to kind of MacGyver a tourniquet, like your standard issue bandana that people have been wearing as like a face mask, that would be pretty effective, combined with like a pen or a stick of some kind. But sure, a belt will do in a pinch if that's all you have.
All right. We have a comment that was sent my way. Might sound stupid, but might want to remind that aspirin is a good idea for painkiller use when dealing with bleeding.
No, that's actually not a stupid question. There's no stupid questions. I'm so used to teaching medical students and residents and nurses I don't really have a great appreciation for what kind of common knowledge is anymore. So I would never want anyone to feel stupid about this. Um, so we specifically asked about aspirin. So I'm going to specifically talk about that. Aspirin, different than Tylenol, which is the same as acetaminophen, different than ibuprofen, which is the same as Advil. Aspirin affects your ability to form clots. It damages platelets. And so it's a common medication, yes, for pain control, but also in patients who have heart disease to kind of thin the blood in a certain way by making platelets less sticky. So I wouldn't recommend you give aspirin to a patient who's injured because you're trying to stop their bleeding. You're trying to have their blood be as sticky and clot forming as possible. And aspirin is going to, make it less sticky, and it's going to make it easier for them to bleed. So I would say Tylenol is good, ibuprofen is good. All of your standard issue other pain medications, within safe dosing levels, like opioids, things like that, are potentially safe, but potentially dangerous in large doses because they can lower blood pressure as well. I really don't want to get into the details of pharmacology because that's an entire semester's worth of talk. But I would say I'd avoid aspirin specifically. I would go Tylenol or ibuprofen if you have that instead.
We'll do a sequel only about pharmacology. Next question. When is there a need to apply pressure to a bleed or a need to pack a wound, but there's no clean extra fabric, gauze, etc. to do so? What would you recommend?
Well, there's always going to be some fabric unless everyone is, running around naked when they're injured. You can always remove a t-shirt. If you're removing the patient's pants with, trauma shears, or you take off the patient's own shirt, you're going to have some sort of fabric. It doesn't need to be medical grade gauze. It could be a bandana that people are wearing. It could be a towel from the trunk of your car that you have on the beach. Any sort of fabric will do. I would say if you truly don't have anything, if it's a bunch of people running without clothes through the woods and you're significantly injured, I would just try to apply direct pressure just above the injured site.
How I choose to spend my evenings is not your concern, Max.
Very good, KG.
We don't have any on deck questions at this point. I'll give folks a moment if they do have any others. Okay, we got another one just came in. Does Max think clotting agents or wound closings are worth buying?
There's some really good agents out there. I honestly don't know what's available on the market because I haven't looked into adding that to my personal supply kit. I will say there's an agent that has a very good safety profile, even in people who are on blood thinners for like medical reasons, called TXA, trans ischemic acid. And that is something that has a pretty good safety profile. You can consider using that, and it's something you can apply directly to the wound. If you have some other clotting agent out there, there's no downside to using it. A lot of them are used. Basically, rule of thumb, anything you apply topically is probably not going to hurt the patient any worse than they're already hurt.
Great. All right, now the question we have here, what if keeping wounds clean? Does mace/pepper spray cause infection? And is milk or water more effective in treating pepper spray?
Oh, this is a great question. So mace, pepper spray, they are topical irritants. So they are by design supposed to make your skin burn, your eyes itch, make you really uncomfortable, make it hurt to breathe, make it really noxious to be there. So you go away from there, right? They're trying to get people to go away from where they're at with the pepper spray. It doesn't cause an infection. Things that cause infection are bacteria, viruses, and those can get into your body if there's a breakdown of the skin. So if you have a deep injury and dirt is in your wound, or if you have a deep injury and just the normal bacteria that live on your skin get into your wound, that can cause an infection. Now, I think the follow-up question was milk versus water. This is kind of perplexing to me. This concept of milk as kind of a cleaning agent. I've certainly seen it before. Specifically in my area, I've seen people who, for whatever reason, the folk cure for people who are on PCP is milk, and I'm not sure why. There's no benefit to milk for wound care. There's no benefit to milk for any sort of toxicologic reason. In the ED, when they eventually get to the hospital, it'll make the patient smell a bit milky, a bit cheesy, but it won't make it any less likely that they have an infection. It won't make it any less likely, based on my understanding, that they're going to have less irritants in the eye. So if I had someone in my emergency department and they had pepper spray in their eye or any other sort of irritating chemical in their eye, we would just do a lot of dilution. So we just, as much water in their eye as possible, as much water in their wound as possible. So the kind of joking phrase is, the solution to pollution is dilution. So as much infection is in their leg, as much pepper spray is in their eye, just put as much water on it as possible. That'll wash it out fine. You don't need to put milk on any wound. You don't need to put milk on any, pepper sprayed eye. I know of no benefit to milk.
All right, next question. Should physicians identify themselves as such at a protest, e.g. with scrubs or an armband, if they're coming with supplies, or is that for some reason not advisable?
I haven't been to a protest in the role of a physician, so I can't speak to specific kind of concepts, but I don't understand why it would be, I don't see how it would be bad if you identify yourself to the folks in the area as someone with a certain, technical skill that could be helpful to them. I think that would make them more likely to rely on you and get appropriate medical care. I certainly know of some friends and colleagues who have acted as kind of street medics at protests in this role. And I know they, do the role, heroically and carefully and safely, and applying all the best kind of medical standards of care that they can in that situation. So if I was at a protest, I would identify myself as a physician, either by talking to people. Probably wouldn't wear scrubs just because it's a very flimsy article of clothing. I'd probably want to wear something that would be a little bit more protective myself. But yeah, I'd tell people I was a doctor. I wouldn't really be worried about that. But I guess that's up for every individual person to decide.
Yeah, and I will say that I do not have medical experience myself, but I do think that there has been some concern recently about certain kind of new normal sort of things that have been going on at demonstrations as far as supplies being targeted and such. So, at this point, I don't actually have anything that I would say I have anything to add to this, but, I think it may be one of those things that best practices may end up evolving as we go over the coming days and weeks.
That's an interesting, it's an interesting tactical argument, KG. Thank you for that. Yes, that's what I was talking about when I said I haven't been there in a role of a physician, so I don't know what I don't know. It's something to consider.
Next question we have here. Is there anything that can be done in the field if the person goes into hypervolemic shock? And thank you for clarifying, the person who sent this to me. That's super low blood pressure.
Yeah, hypovolemic shock. Yeah, so if their pressure is really low, first thing you want to do is make sure it doesn't get lower. So keep all the blood that's in their body still in their body. Unless you have a trunk full of blood somehow that you can transfuse into them, the only way that they're going to get that volume of blood back is by getting to the hospital. So your job is to make sure they don't lose any more of it. So you can apply that tourniquet, you can apply that direct pressure to wherever the injury is. As far as improving their blood pressure, laying them flat, keeping their legs elevated, will have all the blood that's in their legs kind of drop down into the more central parts of their body, where it can go to their heart, lungs, liver, all their kind of vital organs, their brain, obviously. So that's what I would do. I would apply tourniquets. I would control bleeding in whatever way you need to. I would lay the patient flat. I would elevate the legs. And that's about the best you're going to do in kind of an austere pre-hospital environment.
We actually have a couple of comments
Sure.
related to the question of identifying as a physician or a medic. First comment we got here was first aiders will often identify themselves, but they've been specifically targeted in some instances recently. Another comment was police can target medics, but it's probably still best to identify yourself, or at least let some people know you have supply/training. So I guess I'll just quickly add that if anybody here who has experience, particularly as a street medic, at protests, current or in the past, feel free to reach out if you feel that there might be a useful follow-up training we could do in the future. We could all maybe even collaborate and do something, all together again. You can just email me at movementspod@gmail.com. I'll put that into the chat box in just a moment. Next question. Would love to hear basics on triage, treatment of closed head wounds, someone who was pushed or who fell.
Closed head wounds. So I'm trying to think about what could be done pre-hospital. There's really not a whole lot you can do. If somebody has a significant head injury where you're concerned that they're bleeding into their brain, right? They've had some sort of injury to their brain. You really want to get them to the hospital as soon as possible. And what they're going to do is they're going to relieve that pressure in their brain by, stopping the bleeding through certain medications being administered, by administering certain medications to bring down any swelling in the brain, and possibly through a surgery to kind of open up part of their skull to allow the brain to swell safely without kind of squishing it. So in the pre-hospital setting, if you're worried about a significant head injury, really the best thing that you can do for your buddy in that situation is get them to definitive medical care as soon as possible. I wouldn't do anything that delays that. I wouldn't try to mess around with something on the scene. I would just get them to a hospital as soon as possible.
Okay, here. Somebody else added in a comment earlier, link to a Twitter account, reputable ophthalmologist who has debunked the milk thing. I think this has been one of the great controversies of the last few days. To milk or not to milk. I'm definitely on team no milk. Next
Thank
question.
You, KG. I'm also on team no milk, if it wasn't clear about my rambling answer earlier.
Yeah, oat milk all the way. Anyway, for next question, for less serious wounds, what are good practices for preventing infections? Does isopropyl alcohol and or hydrogen peroxide work as disinfectants?
Yeah, the best thing that you can really do isn't anything fancy. It's just irrigation, lots and lots and lots of water. Run it under a sink for a really long period of time. These are obviously, you said, low severity wounds, so like an abrasion, a cut to the hand, something where you're not worried about bleeding to death, but it's uncomfortable. There's lots of water. Alcohol and hydrogen peroxide aren't really going to be of any benefit beyond that. They'll be painful, but they won't really be of any benefit. We all kind of jokingly think back to like Westerns or war movies that we saw maybe as in years past where they like pour whiskey or something on a wound. There's really, in a pre-hospital setting where they're eventually going to a hospital, there's no benefit to that. Other thing to consider is kind of a preventive, specifically for an infection control issue. If you make sure your vaccinations are up to date, specifically your tetanus vaccination, that is a horrific bacteria that can cause a really nasty infection. It's 100% preventable. It's a very common vaccine called Tdap. It's a combination with diphtheria and pertussis, so you can get that in a primary care office with an appointment.
And once you have the Tdap, how long are you immune for?
So the standard question that we ask in the emergency department is when you had it, and if it was within 5 years, we consider it protective. If it was beyond 5 years, we would update your Tdap in the emergency department to prevent that infection. So it's not the worst thing. If you're going to get to an emergency department eventually, you'll be fine. But if you're talking about a period of a really delayed extrication, like that slide of Hurricane Katrina, if you cut your leg on a rusty pipe trying to help your buddy out or escape from that scenario, and you couldn't get to a hospital for days to weeks, that's potentially dangerous. Maybe you could get a tetanus infection. So you can get a tetanus vaccination. That would prevent it.
All right, next question we have here. For moving an unconscious or injured person, what is the proper way to transport them?
Yeah, so I would always worry about some sort of neck or spine injury in this scenario. And so any way to move that patient, minimizing their neck, spine, back kind of twisting, I think would be beneficial. What we do in the hospital when we're rolling the patient from side to side to look at their flanks and their back for any injuries is we have somebody stationed at the patient's head, and we have them use kind of both their hands and they grasp their shoulders and they kind of pinch the head in between their forearms. That way it's kind of a more solid system. And if you do that, that provides some support. There are neck braces that you can buy on online retailers. I will say that the kind of soft collars, the squishy ones that are like almost like a pillow, they don't do anything. They're of zero benefit. The harder ones that are uncomfortable, those actually do provide stability to the neck and are potentially beneficial. If you're talking about an injury to a back, like a rigid board to transport somebody on would be potentially stable. Like when EMS is transporting people, they have spine boards, which are these really uncomfortable kind of plastic, basically devices that people lie on, and then that sits on the gurney. So if you had something like that, that would be a way to transport someone and minimize any exacerbation to a spine or neck injury. Good question.
All right. I'll give folks a moment if they have any other questions. I don't immediately see anything coming in, so I'll go ahead and ask a question. More of a general question, because I think there's a decent number of folks who may watch this training who have no experience or medical experience whatsoever, and who, these sorts of situations can be extreme stress and very, very much, fight or flight sort of, kicks in and all that sort of thing. Max, what advice would you give to somebody who is sort of thinking like, I don't know if I'm ready for this?
Right. It's a great question, and it really draws me back to a quote from one of my favorite books, which is about medical training in the 1970s. It's a book called The House of God by Samuel Shem. And he says, in any sort of medical emergency, the first pulse you take is your own. So before you act, you need to assess what your own kind of mental state is. How am I feeling? Am I super amped up? Am I like super sleepy? Where am I at? And when I know where I'm at, try to take that deep breath, assess the situation, and act. It's going to be frightening for people, especially if you haven't done this, before, or you've done it before, but maybe not a lot. It's a new thing. I would say just try to slow down. And, if you have multiple buddies there, you can always kind of work together, kind of say, hey, do you think this is right? Rely on your friends, rely on people with expertise, but ultimately you'll need to act. Generally, these really severe injuries, they're not subtle. If you see blood squirting out of somebody's arm or leg, if you see like a really steady flow of blood that's just pouring out of someone's leg, that's a bad bleed. You don't need to go to medical school or paramedic school or nursing school or anything like that. You kind of just know it. And so, in that situation, a tourniquet could be really helpful, potentially save that person's life.
All right, thank you so much. We did have another question come in. Are there any other considerations you recommend that we take into account for first aid care as far as the ongoing COVID situation? or is it more likely that we'll cross that bridge later after the pressing medical crisis at hand?
Yeah, yeah. I worry a lot about COVID. You know, the last 3 months of my life, I've been COVID at the hospital that I work at primarily. I worked at one of the kind of makeshift field hospital that they set up, excuse me, in Philadelphia. I work as an elected official at the township level, and so I've been working to prepare my town and coordinate emergency services, coordinate kind of all the specific township services, coordinate how to keep all of our town employees and all of our residents as safe as possible. Um, if I could boil it down to really one thing, um, it's impossible to be socially distant in a dense protest. Wear a mask. Uh, Ideally, it's a respirator type mask as opposed to just like a regular blockage type mask. So you'll see kind of loose fitting cloth or surgical masks. They're generally like rectangular. And then you'll see something like a respirator, which would be like an N95 type mask. And what makes it a respirator is that it's a tight seal around the nose and the chin. And so all of the breathing that's coming in and out is through that filter as opposed to kind of sneaking in through the side. So I would recommend, if you have the capability, a respirator of some kind. So that could be an N95, or that could be like a half mask respirator that you can get at like a paint store. And those will have kind of like a silicone rubbery type material that fits on the lower half of your face, covering your nose and your mouth. And then you'll frequently see like these filters coming out the side of your jawline by your chin. And those will have the added benefit, in addition to filtering virus, they would filter any sort of irritant that's in the air, be it dust or pepper spray or anything else.
Thank you. We're up to speed on questions.
Okay.
So give folks, actually, yeah, I think you have another last little bit here, and then after you're done, we'll go ahead and see if there are any new questions that have come in.
Sure.
You're good to go, Max.
Okay. So I'm going to unshare my screen. Okay. Oh, we have good turnout. So I think you can all see my screen. So this is kind of a mock-up. This is, we'll pretend it's a leg or an arm. It's a yoga mat rolled up. And this is the tourniquet. So I'll demonstrate some basic parts to it. So this is the loop. You see there's kind of like a strap mechanism here. So you can put the leg or the arm through this, and then you tighten that down. And then there's Velcro on this and this. And so it sticks to that. This is the windlass that I was describing. And you want to make it as tight as possible with this looping mechanism. And then this windlass, when you spin it, it kind of gets that last little bit of tightness you need to really pinch off supply of blood. So the mechanism that this works through is you put it above the injury, you tighten it as much as possible, and it cuts off all blood flow going past that. So no blood going to the injury, so no blood escaping from the injury. So all that blood stays, inside the body. Once that windlass is tightened, you can undo this little strap here, and you see here's the little clip. You can put the windlass inside the clip, and you can see it's secure. And then you can tighten it back down, and you see this particular model. Somebody wrote time there, so if you have a Sharpie marker, you can write it there, and that'll be helpful to the docs and nurses and paramedics who take care of your buddy down the road, because they will know how long the tourniquet's been on for, and that'll help with their kind of definitive medical care planning. So I'm going to show you how to put this on yoga mat. You can pretend it's like a thigh or an upper arm. So you loosen it, it's nice and big. All right, let's pretend that's their foot. Okay, you get it above their knee, above their elbow. And you can see I'm kind of strapping it down. All right. The Velcro is on, so you see it's pretty snug already. And now you have this loop and windlass section that we talked about. So you spin the windlass. Oh, and a pro tip, when you're putting this on, keep the windlass part on the outer part of the leg, the outer part of the arm. Spinning this inside someone's armpit or inside someone's like inner groin can be a little bit tricky. So just put it on the outer part of their arm. That way, it's easier to tighten the device. So as you're spinning it, you can see it's kind of really tightening down, and you spin it until you see the bleeding past and the injury past it has stopped. Okay, and we get the windlass, and it's in the clip. So everyone see it's in the clip, and all that tension is kind of getting it in the clip. It's hard to get out, and you just put that over the top to secure it a little bit. You can write the time on there. Now that's really tight. You can see it's kind of flexing the yoga mat. So you can imagine that's going to be really tight on somebody's leg or arm. It's going to be very painful, but it's going to prevent any bleeding at the injury that's past it. So that'll be beneficial. That'll save somebody's life if it's a significant amount of bleeding. Any questions about this, or do you want me to demonstrate it again? I don't know if people want to comment in the chat box and have KG speak it.
Just very quickly wanted to express that I was really struggling to not make a felon joke during that demonstration. If you don't get the reference, ask your Jewish friends. Yeah, are there any questions or requests for Max to demonstrate? Okay, I guess you can move on.
Okay. Well, that's it. I, kind of talked about some basic concepts, how to identify severe bleeding, direct pressure, wound packing, and really the big thing is tourniquet use. As far as like systemic use, I would say if you're going to be going to a protest, or if you're going to be, like a group of people in like a remote area where you won't have access to medical care for whatever reason, everyone has a tourniquet on them. They don't weigh a whole lot. You can even put them on your shoulder like that, and just kind of wear it on your clothes. There are some soldiers who have them kind of built into their uniform. I would say the more that you have available, the more likely that you'll have one when you need it. They're relatively inexpensive. I bought a 3-pack yesterday off Amazon, and I got it delivered 12 hours later. And I got all 3 for somewhere in the mid $20. So you can get a bunch of them tonight if you wanted to, and you could probably have them tomorrow or the next day. And I think the more that they're out there, the more likely that if you need it, someone will have it there. And that's good, right? You don't want anyone to bleed to death on the street for any reason.
Okay, thank you very much. Okay, I think, did we have a new question here? If we want to learn more about first aid, are there any other resources you recommend we read to inform ourselves?
Yeah, so specific to bleeding control, I actually include a number of references in my PowerPoint. And KG, I'm happy if you, with the email, forward that PowerPoint out, or if you wanted to just condense it to the references slide. It's basically all the diagrams, all the statistics that I quoted throughout this. I included as a reference, so I'm not some idiot just making stuff up, and it turns out milk is actually the best thing ever. You'll have some medical references to back these things up. So you can read those. As far as like basic medical references, I'd say anything by like a consensus medical group like the American Heart Association regarding CPR. There's a national group called Stop the Bleed that's run by a national group of trauma surgeons. They are helpful resources for how to control bleeding. And I actually used their material when I was preparing this lecture today, so I'm sure some of the pictures you see there will be repeated. I would say organizations like that, large national kind of consensus organizations that put out like first aid books would be useful.
It looks like someone in the chat box just sent out a link to a free PDF for Street Medic. So thank you for sending that resource. We may include that in the follow-up email that we send. Is anything else that you have for us, Max?
No, I don't have anything for you. I just hope you guys all be safe out there.
Great, thank you so much. So that brings us to time. Thank you so much to you and to everybody for joining this call. So this training was recorded and it'll be uploaded as soon as possible as a publicly available resource. Hopefully we can get that set up tonight. And then we'll send an email out to everybody who registered with the link to the recording. And if you do have any follow-up questions for Max or anybody else, you can send those over to movementspod@gmail.com. I'm putting that into the chat box for folks right now. So yeah, again, thank you so much, Max. I did think that we'd have a chance to be a little silly on this call. I'm glad I was able to sneak a little bit of those in. These are crazy days, but it's important to have those little moments of joy whenever you
100% with you, KG. I will say, as far as follow-up stuff, I'm also happy to receive DMs or ats on Twitter. I think my first slide was my Twitter handle at the numeral 0 and then Max Cooper 0. Feel free to contact me or follow me and ask me questions on social media. I'm happy to reply. I'm semi-addicted to technology, so it'll probably be quicker than it should be.
Great. And that was at 0 Max Cooper 0. Correct?
I can, yeah, I'll screen share so people can.
Okay. Great. And I also typed into the chat box.
Okay.
All right. In that case, that is it. Thank you so much for joining this training. Stay strong, stay disciplined, and remember your training.